Hello, everyone. We are just getting things going. Just want to do a quick check that people can see me and hear me okay. Someone mind unmuting and just letting me know if it sounds and looks okay?
Looks good on my end.
Great.
Everyone's saying yes in the chat too.
Perfect. I'm going to give like maybe one more minute for people to pop on and then we'll get started. Hope everyone is doing well tonight. And thank you so much for joining us. All right, let's just go ahead and get started. So this is our summer webinar series. Tonight we're going to be covering chest pain in children, the broad differential that we as cardiologists consider. So to get started, we'll start with the boring logistics. It's not boring. This is the QR code to sign in, and you actually need to do this in order to claim your CME credit at the end. So make sure you scan this now. This will help track your login time for participation. So for people jumping on late, I'll show it at the end of my presentation as well.
I'm also dropping a link to the sign-in form in the chat right now, just for so everyone knows.
Perfect. I'll give folks a minute to do that. All right, since it's in the chat, I will move on. Disclosure-wise, we have nothing significant to disclose. So I just wanted to say welcome. This is our summer webinar, or it's really fake fall webinar, but technically summer. This is actually our second webinar. We did our first one back in the spring. We covered syncope in that one. So if you haven't seen it, you can go back and watch the recording. We hope to do these regularly, at least twice a year, maybe more. So be on the lookout for more to come. Our goal is to provide educational and CME opportunities for those of you in the community to help get to know our specialty and the way kind of our brains work in our field. If there are topics you'd like to hear about in the future, there's a couple ways. You could either reach out to me or Katina Hunter or someone in our marketing department. You could also, at the end of this presentation, drop a topic in the chat so that we can get your feedback on what you'd like to hear. So why we're all here to talk about chest pain. Chest pain, we all see a lot of it, and our job as the providers is to decide if it's dangerous. Most of the time, the chest pain patients are going through you all before they get to us. So the goal of this webinar is to break it down to consider the broad differential and kind of get inside the minds of us as we see these patients. The format for tonight, I'm going to give you a broad overview and kind of my general way of thinking about chest pain. I'll give you a couple of examples of non-cardiac benign chest pain, and then I'll turn it over to Dr. Hunter Wilson, who's going to cover a potpourri of chest pain causes, and then Dr. Shannon Jones will cover myocarditis and pericarditis. We'll have time for questions after Dr. Wilson's talk and after Dr. Jones's talk as well. So this is the classic presentation. Let's say it's a teenage male athlete who has not mentioned it to his mom for a while, but he has been having chest pain and it's gotten persistent. So he finally does mention it to his mom. Mom brings him in worried. She's heard about all these athletes going down in sports, so she's concerned and brings him in, whether it's to the ED or to the general pediatrician. So how do we think about chest pain? Well, this is the study you'll see referred to in our notes a lot. It's one we all think about a lot. This was actually a study done at our center in the emergency departments at Scottish Rite and at Eggleston in 2011. And I think it really helps put chest pain in perspective. I always tell families chest pain in adults is cardiac until proven otherwise. But most often in pediatric patients, the chest pain is not related to the heart. So let's look at the results of this study. So this study looked at 4,000 cases of chest pain in pediatric ED patients, and they wanted to determine how many were non-cardiac, meaning musculoskeletal, asthma, infection, GI cause like reflux or sickle cell, versus cardiac, which included arrhythmia, pericarditis, myocarditis, coronary ischemia, or pulmonary embolus. They found that 99.4% of the cases were non-cardiac, and only 0.6% of the cases were cardiac. So, kind of going through how I think about this. The goal, obviously, with chest pain is to not run excessive tests on that 99.4% of non-cardiac chest pain patients. But we do want to not miss those 0.6% of serious causes of chest pain. So when I'm thinking through chest pain in general, I kind of break it down in my head as, is this acute pain? Meaning like it's been new over mostly days, sometimes weeks. But is it a new pain? If it is there associated respiratory distress? If there is, I think about pneumothorax. I think about pulmonary embolus. The other thing I think about with acute chest pain is there recent viral illness and inflammatory illness? If so, then myocarditis and pericarditis are a consideration. Pleurisy is another cause of acute chest pain that can be seen with viral or inflammatory states. And pneumonia. Or is the pain chronic? Has this been going on weeks, months, or years? If it's chronic, is it at rest? Is it sharp and fleeting? That gives me, makes me think about precordial catch chest pain. Is the chest wall tender to palpation? That makes me think about costochondritis. Or is it after meals, which makes me think about reflux? Is this chronic chest pain with exertion? That makes me think about coronary anomalies, cardio outflow tract obstructions, or arrhythmias. Now, the note about arrhythmia is that that's more in younger kids who really struggle to differentiate between the feeling of pain or palpitations. Or it could be asthma. So that's kind of how I break down chest pain and what we'll cover in more detail in this webinar. So Dr. Hunter Wilson is going to cover pneumothorax and pulmonary embolus. He's also going to cover coronary anomalies and cardio outflow tract obstructions. Dr. Shannon Jones will cover myocarditis and pericarditis. I'll cover the benign innocent causes like costochondritis and precordial catch. Dr. Mao actually covered arrhythmias when we did our syncope webinar, so tune into that if you want to hear more about that. And then you can guess we're not going to cover it's not the heart types of chest pain, our favorite line in cardiology. So pleurisy, pneumonia, and asthma, we'll keep out of here. So benign chest pain is really, like I mentioned on that slide a few slides ago, it's really the most common cause of chest pain that we see. So my general rule that I live by in clinic is if the chest pain is brief, if it's fleeting, if it's self-limited, and it's long-standing, it's typically benign, and so I'm unlikely to do an echo in those patients. Unless there is a concerning family history, other worrisome symptoms, or comorbidities in the patient. So we'll dive in a little bit deeper on costochondritis. Obviously, I organized this event, so I assigned myself the easiest topic, as you'll see, but let's cover a couple of these common causes of benign chest pain. So costochondritis, we've all seen it. It's classically tender to palpation, or when they make certain movements, part of their chest wall hurts. It's the inflammation in the costosternal joint. It occurs especially after an illness, like a viral illness, if they've been coughing a lot, or if they've started a new workout where they've started doing like push-ups or activities that kind of like stress the chest wall, carrying really heavy backpack, things like that. The treatment is typically 3 to 5 days of around-the-clock ibuprofen and trying to avoid the triggers. So if it happened because they started a new workout regimen, then we ask them to avoid those exercises until it gets better. Really, the mainstay is just patience. This is kind of a stubborn area and a stubborn type of pain. It can linger for sure. I always think of it as like you're constantly breathing and moving, and your chest wall is not really an area that you can immobilize like you can another like joint injury. So it's really avoidance of trigger and anti-inflammatories and just knowing it's benign, it'll pass and you're not in danger. The second benign type of chest pain I'm going to cover, also very, very common. I think I saw 2 of these in my clinic just today, is precordial catch chest pain. This is classically a sharp or stabbing chest pain. It's really sudden and quite severe. This like stops people in their tracks and is really scary for them, but it's quick. It only lasts seconds to a couple of minutes, and it's common and especially in the teenagers, but we see it younger as well. The exact cause of it is unclear, but it's something in the pericardium or the pleura or some sort of a nerve gets caught, perhaps on a false rib or the back of the ribs. But people will describe it's like a sharp nerve-like pain, and it gets worse with movement and deep breath. So it really freezes people up. The treatment, really, there isn't any. It's so random and sudden and quick that you don't know when it's coming, and it doesn't last really long enough to provide any sort of an anti-inflammatory treatment for it. It does typically get better with age, as well as somatic growth as you kind of, the chest wall spaces out and all of that isn't quite so on top of each other. So that concludes the first part of this talk. If you were late, I just want to kind of reiterate, sign in with this QR code. It's also in the chat box. That's the way you're going to get CME credit at the end. It helps track the time. Here are my references, and Dr. Hunter Wilson will take over from here. Dr. Hunter Wilson is one of our cardiac imaging physicians. He does cardiac CT, cardiac MRI, and he's also one of our outpatient cardiologists. So he's going to enlighten you on that potpourri of topics that I alluded to earlier. So I will let him take over.
All right, Dr. McKay, thank you very much. I'm excited to dive into this.
Hunter, I can't hear you. I see your mouth moving though.
Can you hear me now?
I can hear you, Dr. Wilson.
Okay. All right, perfect. Well, excited to dive into this topic, and thank you to Dr. McKay for organizing this. I think it's a very important topic for all of us as providers, as pediatricians, as cardiologists. It's something we see very commonly and share in terms of our practice. So let me share my slides here. Give me one moment. All right, so are folks able to see my slides?
Yep, I see them.
Okay, perfect. Great, well, let's dive right in. So just to reiterate, as Dr. McKay mentioned, what we're really interested in is the needle in the haystack. And we know that broadly speaking, most of the chest pain that pediatric patients have, young adults, is non-cardiac. It's fortunate. I always tell families it's a good batting average to have when we're evaluating for pathology, but we're interested in the dangerous, scary types of chest pain. So in terms of what we'll talk about today, we'll talk about some of the pathologic cardiac causes of chest pain that really cross our minds in the cardiology field when we're seeing patients for chest pain. We'll give a couple bonus cases of some non-cardiac chest pain. I'll give a couple takeaways for you guys to consider in practice, and we'll hopefully have some fun. So I divide chest pain into a couple big categories in terms of thinking about pathologic chest pain. So first big category is coronary conundrums. These are structural issues with the coronary arteries that can cause chest pain in sudden events in kids. Another big issue is abnormalities of the myocardium, so think hypertrophic cardiomyopathy. And then another category I think of as abnormalities of structure. So chiefly we're considering left ventricular outflow tract obstruction in this category. So why don't we start out with coronary conundrums? So there's several big categories in here. The first and foremost, which is often on the tips of our minds in the cardiology space, is anomalous aortic origin of a coronary artery. There's also transeptal course of coronary artery, a little bit more exotic. We'll talk a bit about that. There's anomalous left coronary artery from the pulmonary artery. That's L kappa. Myocardial bridges can occur. And then there's other rare coronary artery abnormalities to consider as well. So whenever evaluating chest pain, and chiefly exertional chest pain, you always have to consider coronary artery origins. there's a lot of variants of coronary anatomy. It's important to note that not all are pathologic, for example, circumflex from the right coronary artery, but there are some that do result in chest pain. And really, the elephant in the room when we're evaluating patients with chest pain is whether patients are at risk for sudden death, because sudden death in athletes, these are stories we read about in news and we hear about from families, and that's what we all want to avoid when we jointly evaluate our patients together. This is a graphic from a big population study. It looked at over 1,400 deaths in sudden athletes and looked at the biggest causes of sudden cardiac death. And so you can see here the coronary artery abnormalities constitute a fairly sizable portion of the pie here. So that's why it's often something we think about first. So to review normal coronary anatomy, coronaries typically originate from the facing sinuses of the aortic root. So if we look here, we can see that the left coronary originates here and right here. And this is the aorta, and it faces the pulmonary artery here. You can see that the origins are perpendicular, they're nice and wide open, and there sometimes can be proximal narrowing with various coronary issues. I'm getting some signal here. Are folks able to see this slide with the coronary origins? Okay, perfect.
Yes, we can.
So I want to make sure we were advancing. Okay. But the pathologic variants can sometimes result in proximal narrowing, and that narrowing can limit blood flow. So the two big categories that we think of are anomalous origin of the left coronary artery from the right sinus. So when we're evaluating this entity here, we can see this left coronary on the left side of the image here comes off from the right sinus. It courses between the great vessels and then continues its normal course. Conversely, there's also anomalous origin of the right coronary artery from the left sinus. And similarly, it originates from an opposite sinus and it courses between the great vessels here. Now, the big question is, why is this an issue? Why is it a problem? If things are getting from A to B, where the coronary distribution is supposed to be, why is it an issue? The problem is that during exercise, the thought is that great arteries are more dynamic. Imagine running through the basketball court, your great vessels are pumping blood out. And what that can do is cause some compression of the anomalous coronary arteries. It takes an interarterial course, a course between those great vessels. And what can happen is that with reduced blood flow, you can have myocardial ischemia that can result in chest pain, sometimes arrhythmia, myocardium which needs blood can sometimes be arrhythmogenic, and then ultimately syncope and sometimes sudden events. This is where we're trying to capture patients here, but keep arrhythmia and exertional syncope in the back of your minds as well when taking histories of patients in clinic. Those are, I think, red flag symptoms. There's a couple differences in left off the right and right off the left. The left off the right is an increased risk variant. The left coronary artery supplies the left ventricle and a bit more of the overall myocardial blood supply. The right a little bit less. Left off the right is fortunately less common. Right off the left is more common. Left off the right, we'll typically do a CT and exercise test, and in many cases, right off the left as well to help risk stratify and evaluate the anatomy. And we'll often sports restrict for left off the right, and for right off the left, it depends. We may not sports restrict. I think that depends a little bit if it's an incidental finding or if a patient's referred in truly for chest pain, which is exertional. And then left off the right is a probable surgery, and right off the left is more a sometime surgery. There's factors beyond the origin to consider as well. It's not just that interarterial course. The other morphologic substrate to consider, which we're getting more insights on with newer imaging technologies, is one, is there an intramural course? And what I mean by that is sometimes the vessel will actually course within the wall of the great vessel here, and that results in more elliptical orifice, and that can be prone to more narrowing and more obstruction. So that's a big consideration. Is it a slit-like orifice? Is it like kind of a narrow orifice in contrast to the typical broad circle of normal coronary origin? There's other factors as well, height, relationship to intracoronary commissure, and we can get a lot of that information with newer imaging technologies. So I'd say our typical approach in practice when confronted with an anomalous coronary artery, that question is first diagnose, and we'll often have echo for our mainstay of diagnosis initially. Sometimes it's discovered incidentally. Sometimes for evaluating patients, for example, with chest pain, it's discovered based on symptoms. We'll typically sports restrict patients, and then we'll typically order additional testing. Exercise tests help stratify and evaluate, is there any ischemia or ST segment changes with exercise? We'll do a stress echo sometimes to look for regional wall motion abnormalities that suggest there's not enough blood flow getting to certain portions of the heart. And I'd say a cardiac CT has really been a game changer. It evaluates and provides information on the subtle morphology of the coronary artery beyond what we can see on echo. And then from there, we'll counsel families. We'll discuss whether surgery is indicated, whether we continue to monitor. And as part of our team, we'll get group input sometimes as well and kind of sit down with the surgeons, the rest of the cardiologists on our crew, and just really talk about patients specifically and decide what the best course of action is. I do echocardiography and CT, so I have to show some echo pictures. And here's a nice echo picture of an anomalous left coronary artery. So you see that blue streak right here that's going between the great vessels, and you can conceptualize that may be compressed if these vessels are pumping quickly and getting a lot of blood flow out. This is that same patient who's had a cardiac CT. We can see here the anomalous left coronary artery coursing between the great vessels. This is a 3D reconstruction here, and this is an intraluminal view. So we're reconstructing the data set to give a sense of what things would look like from the inside. So this is something akin to what a surgeon might see if they take a peek inside the aorta when they're doing the surgery. And I can tell you, we'll do a lot of these reformats on our images as part of routine care. And sometimes it's a real game changer when you put this up and, show this to a surgeon, and it can really help conceptualize what the best strategy is for patients in a very individualized fashion. There's several recommendations for specific cases. In brief, patients with anomalous aortic origin of the coronary and ischemic chest pain or chest pain felt to be ischemic should be activity restricted and offered surgery. Anomalous left coronary artery, the second bullet point here, those patients are generally offered surgery. And then anomalous right coronary artery, it's a bit more nuanced decision making. Often we'll evaluate those patients for ischemia, do exercise testing, CT. But if all that testing is reassuring, if we think the chest pain, if they have chest pain, is perhaps not cardiac in nature, we'll consider whether or not we need to offer an intervention or a surgery. And again, that's driven a bit more by symptoms as well. If a patient's coming with exertional chest pain, we'll probably lean more toward intervention, meaning surgery in that patient population. This is an interesting coronary conundrum here. There's an entity called a transeptal or transconal coronary course. So the left coronary artery originates abnormally, but in contrast to a typical type of anomalous origin, it actually courses within the conal septum. So it kind of takes a deep dive beneath the aortic root in that tissue below the great vessels. This is a 3D reconstruction from a case at our center here, and we can see that left coronary kind of dives beneath the aortic root and extends in a transeptal course. Then it pops up and then courses along the epicardium distally and then bifurcates distally. There's good and bad news. The good news is the transeptal course is felt to be a little bit lower risk than a course, frankly, between the great vessels. The downside is it's a little bit harder to treat surgically. You can imagine having to kind of unroof and open that coronary, kind of bring it up to alleviate the potential nidus for obstruction. So there's no consensus guidelines for this case. It's more of a nuanced counseling and decision-making when we are confronted with these patients. So myocardial bridge, what about the distal coronary arteries? We're giving the proximal coronaries a lot of love, so what goes on distally? Myocardial bridge refers to an intramyocardial coronary artery segment, and what I mean by that is typically the coronary arteries run along the surface of the myocardium. But distally, they can actually dive within the myocardium, and we're seeing this more with new imaging technologies, CT in particular. But this is something that's associated with hypertrophic cardiomyopathy, but also we can see this in normal hearts as well. This is a graphical depiction of what a myocardial bridge is here. On the left, we can see an epicardial course of the coronary, just coursing along the surface and giving little vessels which feed the myocardium. Here on the right, we can see a myocardial bridge. And you can conceptualize that with exercise, exertion, that muscle could potentially kind of compress that coronary dynamically and cause obstruction and difficulty with distal flow. This is an example from our center of a myocardial bridge here. Again, showing lots of pictures here. It's what I do. But this coronary vessel is coursing below the myocardium here with myocardial segment over top of it. And here in short axis, we see the vessel kind of down the barrel. We see an overlying myocardial segment here. So this is a myocardial bridge of the left anterior descending coronary. Now, these cases are often diagnosed by CT. It's kind of a similar workup pathway in terms of how we evaluate these. Fractional flow reserve is an entity, a diagnostic technology, which can give a sense of how much compression may be contributing to distal flow issues. There's surgical options. Again, no consensus guidelines. So these cases we would address on, I think, a case-by-case basis, really get group input on what we think the next best steps are for patients confronted with this type of process in the setting of chest pain. I want to shift a little bit. We're still in the coronary range, but I want to talk about coronaries coming off not a different portion of the aorta, but rather a different great vessel, and that's anomalous coronary artery from the pulmonary artery. The pathophysiology of this is interesting. Here in the graphic on the right, you can see the left coronary artery, or right coronary artery here comes off normally. The left is coming off the pulmonary artery. What happens is after you're born, your pulmonary artery pressures, as we know, are elevated initially. Your PVR in utero is high, and your pulmonary vascular resistance drops in the first month or so of life after you're born, but initially PA pressures are high. With a fall in pulmonary artery pressure, there's retrograde coronary flow, and that can cause myocardial ischemia, that can translate into angina, irritability, and over time collaterals can develop from that right system to supply the segments that are supplied by the left coronary system that arises anomalously. There's risk of arrhythmia and sudden cardiac death in this entity. A typical presentation, I'll start here on the left in the graphic, and again, there's higher perfusion pressure initially with higher pulmonary vascular resistance. There's not many symptoms, but over time, the pressure falls in the pulmonary arteries and there's less blood flow going antegrade, and then eventually the flow starts to go retrograde. It's not as much an issue of cyanosis, meaning deoxygenated blood going out to the myocardium. If you think about it, we have a lot of patients who are cyanotic at baseline, or single ventricle patients who do okay. It's more so there's not pressure to drive flow into the coronary to supply the myocardium. So that translates into lower perfusion pressure, angina, irritability. And then with flow reversal later on, there's ischemia and then myocardial injury. So the symptoms can occur early in life, so 2 to 4 months. This is kind of an interesting flavor of chest pain. We think about the athlete doing sports, but this is an infant often that has, pain, which can be chest pain, and that translates into irritability, failure to thrive, tachypnea. When you think about it, exertion for infants is feeding, and so often trouble with feeding can be a symptom. Early diagnosis is important. It's got a very high morbidity and mortality. Sometimes myocardial damage can be irreversible. I want to show this EKG. I think there's value for any folks involved in urgent care, the emergency department setting. If this is ever an entity to consider EKG, because you can see here often there's classic changes like in the lateral leads ST segment elevation. That's clearly pathologic here. Here you can see ventricular ectopy indicative of a sick myocardium. And here you can see Q waves in AVL. We'll often see short, shallow Q waves in the inferior leads, but here in AVL and in the lateral leads, that's abnormal. These findings together should suggest L kappa. There will often be a grossly abnormal EKG. Some more pictures here. So contrast this with the previous echo picture. We're looking here at the pulmonary artery here and the top of the color box. And we can see here the blue is actually flow going retrograde through the left anterior descending into the pulmonary artery. So this is L kappa with retrograde flow in the left coronary artery system. It can be very subtle diagnosis on echo in many respects, but there's other clues as well. For example, here in short axis, we're looking at the left ventricle, pumping blood out to the body, and we can see the lateral wall isn't squeezing as well as the ventricular septum. So this is regional wall motion abnormality attributable to that left system not getting as much blood flow. So this is kind of a chest pain with an asterisk. It's true chest pain, but it presents very early in life in infants. Some patients can survive past infancy. And if that's the case, it's because collaterals from the right system are developing to supply the distribution of the left system. And the coronary artery perfusion may not be as robust later in life in general. So sometimes you can have demand ischemia, your coronary supply can't supply what your heart's requiring. That can translate into chest pain, arrhythmia, cardiac arrest. So this could be, I'd say, chest pain manifestation of this entity that's maybe missed earlier in life and presents later in life for those reasons. This is an example of what a heart might look like later in life. So again, take that picture from earlier on, and this is a case at our center, looking at the heart from a CT and a cinematographic fashion. And we can see here that dilated left system that's getting collateral supply from the right system, and this left system is coming off anomalously from the pulmonary artery here. A couple recommendations. Surgery is generally recommended for Alcapa discovered later in life. It certainly is early in life. For patients with an almost right coronary artery and symptoms that are perhaps consistent, then surgery is generally recommended. There's some other different recommendations and nuance, but generally our center will perform surgery for anomalous coronary artery, certainly in infants at time of diagnosis, generally for older patients as well. Some rare coronary issues to mention and discuss. So atherosclerosis, almost unheard of in kids, but this would be in the setting of familial hypercholesterolemia. The AAP guidelines, I think, from a lipid screening standpoint, a little bit controversial. AAP recommends lipid screening 9 to 11, then later, when kids are older, transitioning to adulthood. The Preventive Task Force and AFP, family physicians, say maybe not as much evidence. I think what we're overall trying to get at are really to identify those kids who have really high lipids. I'm talking like 300, 400 LDLs, not the 130, 160. And to identify those patients who may need early aggressive statin therapy and potentially plasmapheresis to reduce risk of early atherosclerotic change, which can translate into chest pain. Again, this is a very rare entity. I haven't really seen chest pain I've thought to be anginal like the adults would experience in my practice. And then coronary aneurysm is something to keep in the back of the mind as well. And consider in discussing with your patients any history suggestive of possible Kawasaki's in the past. Or in this day and age, MISC. We'll see what that cohort looks like several years down the line for our patients with MISC who may have had coronary involvement. There's risk of thrombosis and stenosis with coronary dilation, aneurysm, ischemia, chest pain can occur. So correlate with history and keep this entity in the back of your mind as well. All right, so coronary conundrums in abundance. I think with that, I'd like to transition to a different category, which is abnormalities of the myocardium. The big thing that we think about in this setting, there's different entities, but what I want to focus on is hypertrophic cardiomyopathy, and that's what we all think about, what we don't want to miss in our practice. Now, HCM is a genetic entity, as well know, and it's disordered array of myocytes that results in ventricular enlargement that can cause outflow tract obstruction, and the disordered myocytes can increase risk of sudden cardiac events. And this is perhaps the most prevalent cause of athletic sudden cardiac death if you look at that pie chart. Chest pain can be a manifestation, and this is certainly something that's important to diagnose for many reasons. The chest pain and hypertrophic cardiomyopathy could be multifactorial. So there could be small vessel dysfunction, as the vessels kind of get through those disordered myocytes, maybe the blood supply isn't as robust. There can be left ventricular outflow tract obstruction, and that can lead to more demand from the muscle to have to pump harder and sort of cause a demand ischemia we see down here. If you have more demand, you can't match the supply with small vessel dysfunction, you could have anginal or chest pain type symptoms. And then myocardial bridging is seen more frequently with hypertrophic cardiomyopathy. The typical approach for HCM is we have initially a suspicion of diagnosis. So when referred for patients where chest pain or family history is concerning, we'll get a detailed family history. We'll do our exam. We'll consider echo based on the findings in EKG. We'll sports restrict if we have any suspicion of the diagnosis. Additional testing is typically an exercise test. We'll sometimes use stress echo to look for dynamic outflow tract obstruction. Cardiac MRI can really help to risk stratify and evaluate for scar. We'll evaluate rhythm, and we'll sometimes consider genetic testing. We have a genetic counselor as part of our group, and can really kind of plug them in for the latest and greatest in terms of what the most sensitive testing is that's available at the current time. We'll counsel patients based on the findings. We'll risk stratify. We'll talk about sports. We'll talk about ICD. We'll consider family testing. And this is an example of kind of a borderline case. This is a patient who was seen in clinic, and the myocardium doesn't look clearly thickened, but it's a little bit borderline. It looks very hyperdynamic, which we can sometimes see in HCM. A 4-chamber view here, looking at the left ventricle here on the right of the screen. And so we refer that patient for an exercise stress echo, and we can see here with exercise, there's almost complete collapse of the cavity. And when we measure a gradient with echo, we get a gradient of almost 200 millimeters mercury. And what that means is the ventricle closer to the apex is having to pump at a pressure about 200 millimeters mercury higher than the top chamber, which if you have a normal blood pressure in a kid, maybe 100 millimeters mercury. So you can imagine with that demand, you need more blood flow, maybe not as robust supply, that can result in potential ischemia and chest pain. This is a cardiac MRI from a patient with hypertrophic cardiomyopathy. Cardiac MRI provides a really good assessment of the myocardium, is a little bit more sensitive than echo in many respects. And one of the powerful aspects of the technique is it can evaluate for myocardial scar. So this bright spot here is actually scar within the thickened portion of the heart muscle. That can be an important aspect of prognosis and risk stratification for our patients. There's guidelines for HCM. So there are 2024 guidelines here. A lot of the guidelines are for adults. We'll start reasonably, translating them into guidelines for kids, especially as they start translating into adulthood. But bottom line is there's lots of nuance in decision-making and discussion with families about ICDs, medications, whether or not surgery is needed, family counseling. Sometimes patients can do sports. Again, with exertional chest pain, we'd be a little bit less or more concerned about offering that clearance. And I'd say as part of our group, we do have a specialized HCM clinic who really sees a lot of patients throughout Georgia with hypertrophic cardiomyopathy. A lot of patients will end up there for evaluation or follow-up. And then finally, to pivot, I'd like to move to our last topic, which is abnormalities of structure. The big things we think about for structural abnormalities with chest pain are aortic stenosis or supravalvular aortic stenosis or subaortic stenosis, basically left ventricular outflow tract obstruction. And why does aortic obstruction cause chest pain? What can happen is that there is first aortic narrowing, and that can cause left ventricular hypertrophy. Your heart muscle gets larger, thicker. There's increased demand with more muscle, and you can have reduced supply. If you're have significant enough aortic stenosis or left ventricular outflow tract obstruction, then perhaps your heart can't quite keep up with the body demand. Your coronaries come off your aortic root, and so that can translate into issues with blood flow to supply the heart. And demand ischemia that can theoretically result in chest pain. So aortic, supravalvular, and subaortic stenosis all have kind of a similar mechanism and pathophysiologic basis of chest pain. Supravalvular aortic stenosis, I want to just mention, think Williams syndrome or elastin issues. And those patients are very high risk and typically need cardiac anesthesia. They can often have coronary ostial narrowing, things like that. I do want to take away to be that if you have a patient with Williams syndrome, they need clearance for surgery. That should generally be done with cardiac anesthesia, and they'll often have aortic narrowing and issues in that regard. Fortunately, many patients with significant aortic obstruction will have a murmur if there's significant aortic stenosis, so that might be a more common method of presentation than chest pain. Aortic stenosis is one of those lesions that more frequently requires exercise limitations, so we're more thoughtful about giving kids the all clear for exercise in the setting. There's a lot of different therapeutic options for aortic stenosis. Our typical approach would again be to start with exam, echo, really delineate and nail down the mechanism of aortic obstruction that delineates a lot of the procedural options that might be available. We'll typically sports restrict if there's any significant aortic stenosis, and we'll get some additional testing. That might be exercise testing or in some cases cardiac catheterization for both diagnostic and sometimes therapeutic purposes. Genetic testing if there's any associated aortopathy like Williams syndrome, for example. And we'll then risk stratify and consider what, if any, interventions are required. Bicuspid aortic valve is a big cause of aortic stenosis, and if that's the case, then we'll get a good family history and often recommend screening family members as well. This is an echo showing patient with aortic stenosis. You can see here the left ventricular myocardium is a bit thickened, and then here on the right we can see there's turbulent flow. That's that speckled flow here passing the aortic valve. So pretty significant obstruction in this patient when we did our echo measurements. There's a wide range of exercise restrictions. I won't go too much into all the nuance, but generally patients with any significant aortic stenosis will typically evaluate yearly and have discussions about exercise clearance. Asymptomatic athletes with severe aortic stenosis, again, even if no significant symptoms, will often restrict to very low intensity activities. Special bonus, as promised from Rachel, a couple of non-cardiac causes of chest pain. So I want folks to keep pulmonary embolism in the differential. It's rare, but it can happen in children and young adults. So the presentation we're, I think, familiar with, there can be tachypnea, tachycardia, chest pain. And OCP use and previous thrombosis are risk factors. So send these patients to the emergency department. This is a patient here with a pulmonary embolism shown here on the left, that dark spot within the left pulmonary artery. And then right here is an interesting echo finding called McConnell sign, which basically shows some RV dysfunction. This is the right ventricle here, which can be associated with an acute rise in pressure associated with pulmonary embolism. I'd say keep DVT in your differential as well when evaluating patients with any leg swelling or leg concerns. Pneumothorax can occur as well. Spontaneous pneumothorax is something that is acute onset. Typically, it's pleuritic. There's dyspnea. We think about this in association with our connective tissue patients. Often Marfan syndrome is a common association. And it's really the most prevalent in teenagers through the young adult age range. So keep that in the back of the mind. A couple takeaways, again, points of emphasis. Number one, I'd say that exertional chest pain, or parenthetically, it's not the focus of our talk, but exertional palpitations or syncope can be worrisome. So consider cardiogenic causes for chest pain in that patient population. I'd say don't miss Al-Kappa. That's the infant chest pain of our talk here that can present in the first few months of life. Again, fussy, irritable infant outside the bounds of what's usually seen, often failure to thrive, often trouble with feeds. Coronary abnormalities in HCM are more frequent causes of sudden cardiac death in athletes, and they can sometimes present with exertional chest pain. And then finally, I'd say risk stratification is really key to determine sports restrictions and need for procedures. So for each patient we evaluate, we really want to have a nuanced discussion and come up with the best plan for the patient and the family based on all the findings. So I think from an initial evaluation standpoint, whenever we see a patient with chest pain, we consider what, if any, further testing is needed. Within our group, we can do echo, stress echo, exercise testing, cardiac MRI, and then there's HCM clinic and genetic testing available as options as well. I'd be remiss if I didn't mention we're very excited about the new hospital, Arthur and Blank. This is our new MRI scanner, which I'm nerding out a little bit today. I'm over here today helping tweak some of the protocols. So we really aim to be comprehensive in our imaging and what we offer to our patients here at the new hospital. So we have new MRI scanners, new CT scanners, and we're very excited about the technology. I'd say finally, from my standpoint, we're always here to help. So if you ever have a patient you're concerned about, don't hesitate to pick up the phone and give us a call. We're always happy to chat, see patients sooner if needed for clearance, and really partner with you guys in taking care of your patients. So with that, I will end here and pass the torch.
Thanks so much, Hunter. At this point, we can take a little break and answer any questions that may have come up for Dr. Wilson's talk or my talk as well. So people can either post them in the chat box or you can unmute. This is a open forum, safe space. If you want to unmute your mic and go ahead and ask us whatever questions you may have.
All right, so now everyone should be able to unmute themselves if they'd like to. So go ahead.
It looks like there's one in the chat. Can you walk us through how to best get an EKG done through your office? Oftentimes, I just want to start with an EKG and not a full consult. Can we just send a prescription for an EKG and get a reading that way? Yes, EKG only is definitely, we get those almost every day I'm there. I think the referral form, I'm pretty sure it's the same one, but rather than putting consult, you just put EKG. And then that triggers just a nurse only visit for EKG. A physician usually reads it the same day and sends results back. My staff in my clinic will often actually even show me the EKG before they let the patient leave, just in case there is something really significant on it. But if it's like just a minor abnormality, what we'll often do is call you and call the patient and then get them back later for a visit. If it's something really serious where we're actually really worried, we'll usually add them onto clinic the same day if needed. I think that's really unusual, though.
Yeah, I'd say same on my end. We'll often look at the EKGs while the patients are there, or if not, we'll read it same day, and that will get faxed back to you guys. And again, if there's anything really abnormal, concerning, we'll work on that as needed and as dictated by the acuity.
Mhm. Question: Pediatricians see colic not infrequently and has a common pattern. Should we consider Alcapa? And how to suspect in a colicky infant?
Yes, that's a great question and very fussy. Infants are quite common. I see another question to that effect. I'd say generally what I've seen, and Dr. McKay can jump in as well, but it's often patients that are just like fussy out of proportion to, what you'd expect. And it's often associated with failure to thrive, in particular, really fussy with feeding. Often the irritability is kind of the type that would end up not necessarily just in an ambulatory setting, but maybe in like urgent care or emergency department. Um, but those would be the biggest things, just something that's kind of out of proportion to what you'd typically expect for the, beyond the two standard deviations of fussy infants that are commonly seen in practice.
Yeah, and I think they often start getting sick. They look unwell the more it progresses. So there's a few other things like Dr. Wilson mentioned. You'll often hear a mitral regurgitation murmur when it gets pretty far along because the mitral valve starts leaking a lot. They'll be tachypnic. They'll stop taking feeds. They won't gain good weight. So they end up looking like a heart failure patient as well. So if you have a baby who's growing great, feeding great, no big liver, breathing comfortably, but they're just fussy, then I think it's unlikely to be Alcapa. But if, like Dr. Wilson said, they're just above average fussy and you're seeing anything else that makes you think they may be in heart failure, that's when you should consider it. It looks like, what is the range of tachycardia in infants with Alcapa? I mean, tachycardia can certainly develop as heart failure progresses. I don't know if the question is more like, what is the heart rate range? I think that's a tricky question because they're often fussy patients. So it can be 180, 200 beats per minute, but it could just be irritability or it could be tachycardia from the heart failure. That's also tricky. If you have a fussy infant who has reflux, their heart rate may get that high as well. So it's really the compilation of all the symptoms. Occasionally, I've seen patients with costochondritis that recurs over time. Do I need to be concerned about considering any other etiologies, autoimmune, etc.? I I personally have not seen like an autoimmune condition that has recurrent costochondritis. It's not something I think of. I don't know, Dr. Wilson or Dr. Jones, if you guys have seen that, but I have seen patients who come back over multiple time periods with costochondritis. Do you
Yeah,
guys?
I think I would usually expect to see other systemic findings that make me concerned for an autoimmune process. If it was isolated to reproducible chest pain over the costochondral junctions, I think I would treat it as recurrent costochondritis and not delve too deep. If they're having a ton of other systemic findings, then maybe look for something more.
I agree. That would be my approach as well.
It seems I just do an EKG and chest x-ray due to the low cost and reassurance for families. It also prevents doctor shopping and ER visits later that night versus reassurance alone. What is your thought on ignoring a vibratory stills murmur versus tell them they have an innocent murmur for 1 or 2 visits? What is your thought? I think maybe the question is getting at, do you even mention it to the family if you feel like it's an innocent murmur? I personally always do, especially with kind of how transparent the notes have gotten, and I will usually document an innocent murmur in my assessment. I know it's different from the pediatrician side, but I want them to know that I heard it, and I'll often say, I just want you to know I heard this murmur. If your pediatrician mentions it later, you can let them know I heard it as well, and I think it's an innocent murmur, since they're already here, just so they know that I've assessed that. But I just always worry, especially with like how many people go on my chart now. I always worry about patients seeing a diagnosis that I haven't talked to them about and getting worried because it wasn't discussed and I don't want them jumping to conclusions. So I err on the side of mentioning it.
Yeah, I'd say
Not
same on my end as well. Probably worth just mentioning, saying it sounds reassuring. Then also, if they go to different provider like urgent care, emergency department, it's mentioned. It's kind of on the back of the minds. And I'll mention sometimes in discussion with families too that murmurs can be louder, like in the setting of illness, fever, innocent murmurs. So I'll kind of instill that for the back of families' minds as well when I discuss murmurs with them.
Yeah. Let's see. Not about chest pain, but with suspicion of hypertension, do we refer to cardiology or nephrology? Great question. I think both subspecialties see hypertension. We see a good bit of it. I know nephrology has a specific hypertension clinic that they do. For me, it kind of depends on what the risk factors are, if and especially if there's any concern for coarctation of the aorta. So if you're not feeling good lower extremity pulses, or it's really super high, or I don't think many pediatricians do an upper and a lower cuff. But I think both subspecialties see it as the answer, and I don't think anyone kind of owns it as just theirs. I myself will still sometimes refer to nephrology if it's like a really young patient and I've done a cardiac workup, and there's no coarc, there's no LVH, but I do the basic renal labs. But there have been several that I've consulted nephrology to say like, hey, is there anything else I'm missing from a kidney standpoint? Because this is really unusual. So I would say either is the answer. Isn't there a slipped rib syndrome, a floating rib? Is that the catch thingy? There is also that. I think there's a lot of overlap between those two symptoms. I kind of think of it and describe it as the same. I'm not sure if that's technically correct or not, but it's basically like a nerve getting caught within the rib. So yes, I would put it in the same boat as precordial catch. During bronchiolitis season, when infants have poor feeding and tachypnea, which infants should get a chest x-ray and an EKG? Poor feeding and tachypnea. Yeah, I mean, I think that definitely you have to kind of look at all of the symptoms. Do they have a really snotty, runny nose? Are their lungs crackly like bronchiolitis? I think the kids that always worry me when I get a call from the ER are there's no viral symptoms. This kid is just comfortably tachypnic. They have a big liver. Those are the ones that really worry me. And then the chest x-ray shows like a big heart on chest x-ray. So
Yeah.
I would say the absence of viral seasons, but there have been. I mean, we've all seen them that it looks like a viral type picture and you would expect them to be getting better and they're not, and we find something later. I think that's rare, but it's happened for sure.
And I keep in the back of mind too, is this kind of a smoldering chronic process and the patient's not doing well, kind of falling on the growth percentiles, or is it like an acute, viral infection, congestion, 2 to 3 days, a blip in the trend of an otherwise reassuring growth curve and clinical trajectory?
All great questions. There's a comment, guidelines for cardio referral for syncope. We don't have like specific guidelines for syncope, but I would say certainly my red flags would be exertional syncope, or syncope that just doesn't follow the classic like vasovagal or orthostatic syncope. It's not when they're standing up too quickly. But we see a ton of those referrals too, and we're happy to see them, especially in kids where you've already advised them to drink more water, eat more salt, and they're still refractory. We're always happy to see those syncopal kids. Also, I mean, if there's any sort of family history of sudden death, young people with heart disease, any other concerning symptoms the patient has, those are all absolutely valid reasons to refer for syncope.
Yeah, I tell my patients that I use the mnemonic WIPE, WIPE, so syncope without prodrome, syncope with injury, which would imply that you don't have enough forewarning to brace yourself. Syncope with palpitations or syncope with exercise are the patients that I usually give more of a workup.
I like that.
Thank you.
All right. I think for the sake of staying on time, I will turn it over to Dr. Shannon Jones. She's already chimed in some, but she, just to give a quick introduction, she is the jack of all trades and the master of them. She spends time everywhere within our practice. So she's outpatient in general cardiology clinic. She also does inpatient time on the cardiac acute care unit or CACU. And she also does consulting on City Call. So she's going to be talking to you about pericarditis and myocarditis.
All right. Thank you, Rachel. Let's get this pulled up. Okay. So as Rachel mentioned, my name is Shannon Jones. I am going to be talking about acute chest pain in the pediatric patient, focusing on pericarditis and myocarditis. As Rachel said, I cover both outpatient clinic, and then I also do about 1 week out of 4 on the inpatient unit at Eggleston, soon to be AMBH. So I think I have a little bit of a unique perspective because I see a lot of patients for chest pain in my outpatient clinic, and then I also see those same patients when they end up getting admitted. So I think I see the gamut of the non-cardiac to the cardiac chest pain. So goals of this talk. So I think it's important to emphasize here that the vast majority of cases of chest pain in pediatric patients are non-cardiac. So the idea here is to discuss signs or symptoms that would make you more worried that a patient is one of those less common cases in which they're suffering from cardiac chest pain. Did that? Uh-oh. Hold on 1 second. Sorry. My slide is not advancing. Let's see. Nope. Okay, does that showing up now?
It is.
Yes, I can see it.
Okay. So we're going to talk about 2 of the more common cardiac causes of acute chest pain. So we're going to talk about some red flag symptoms, exam findings, or test results that would make you more concerned about a cardiac etiology of chest pain in a pediatric patient. My hope is that you'll have a general understanding about the diagnosis and management of pericarditis and myocarditis and our recommended follow-up, and then have an understanding of the implications of activity restrictions with one of these diagnoses, because presumably you'll be seeing them in your clinic as well. So I want you to understand what our guidelines are and why we follow them. So I thought it'd be helpful to go through 2 cases. One is a patient that I cared for on the inpatient unit, and the other is a patient that was inpatient and then I followed in my outpatient clinic. So the first case is a 15-year-old previously healthy male who presented to cardiology clinic with a chief complaint of chest pain. He had been seen at an outside hospital ER about 2 days prior and was started on ibuprofen. He described his pain as sternal, and it felt heavy and lasted all day. It was constant and was worsened when he was laying down and with deep breathing, and he was endorsing some shortness of breath. He'd been seen at an outside hospital ER 2 days prior and reportedly had a borderline EKG, but a reassuring chest x-ray, and was sent to cardiology clinic. They did not check labs in the emergency department when he was seen. He did have low-grade temperatures at home and then in the ER as well, and he was started on Motrin, but it was unclear whether that was scheduled or just ordered as needed. So in our office, he was mildly tachycardic with a heart rate of 100 and a little bit tachypnic with a respiratory rate of 32, but had normal blood pressure. In our clinics, we usually obtain an EKG before we see the patient, so we can actually look at it before we go in and get the rest of the history. And this was the EKG that he had in our office. This is notable for sinus rhythm. He has left axis deviation. He was not tachycardic when they did the EKG. But what I want you to notice is that there's diffuse ST segment elevation, and then there are inversions in leads V1 and AVR. So I've circled those here. On physical exam, he was tachypnic and was described as being diaphoretic, and there was a rub that was audible on exam. And so in the setting of that EKG and that physical exam finding, he had an echo. I do not trust videos in my PowerPoint, so sorry, they're all still images, and you'll have to trust me, but his function was preserved, but he did have a small pericardial effusion that was circumferential and was larger near the right atrium, which you can see on the left of your screen here. Because he looked like he did not feel well in clinic and was diaphoretic and had persistent symptoms despite being on Motrin at home, he was actually sent to the ER at Eggleston with plan for admission for further treatment and monitoring. It's worth mentioning that that's not always necessary with this diagnosis, but in his case, he looked ill, and so it was felt that he would benefit from being inpatient. In the ER, they got some basic labs. His electrolytes were generally reassuring. His creatinine was a little bit high per our normals, but he was a bigger teenage kid. And they checked a BNP and a troponin, which were both reassuring. He had a chest x-ray that was notable for cardiomegaly, which interestingly was different than when he'd been seen in the ER a few days prior. And then labs were notable for elevated inflammatory markers. And the initial set of labs is on the left of the screen. So his initial CRP was 11 with an ESR of 43. So I've already given this away with the title of my talk, but this is acute pericarditis. So a few things to point out that were important with this patient's presentation. His chest pain was worse with supine position and with deep breaths. It was relieved with leaning forward, which is classic for pericarditis. He also had associated low-grade fevers and a friction rub that was audible on exam. And it's worth mentioning that he looked like he didn't feel well. He was diaphoretic in clinic. He looked like ill. So all of those things can kind of tip you off that something a little bit more significant is going on here. These are two papers. I have the full citations at the end of my talk, but these are two really good review articles that go through diagnosis and management of pericarditis. So if you're interested at all, these are two great references to have. One of them is from Jack, so that's out of the US, and then the other is the European guidelines, and that's a really great paper that walks through a lot of the diagnosis and treatment. So what is pericarditis? Let's first talk about what the pericardium is. That's a double-walled sac that contains the heart and the roots of the great vessels. It has two layers and encloses a pericardial cavity and serves to fix the heart to the mediastinum and protect it against infection, and it lubricates the heart. Usually there's a small amount of pericardial fluid that keeps the heart lubricated. Acute pericarditis is an inflammatory condition that can occur with or without effusion, and it refers to inflammation of the pericardial layers and is the most common form of pericardial disease. Diagnosis requires two of the criteria listed here. This is a table out of that European guideline paper that I referenced on the prior slide. And you can see that the four criteria are presence of pericarditic chest pain, a rub on exam, widespread ST elevation or PR depression, or a pericardial effusion. Chest pain is the most common presenting symptom by far, and it's seen in up to 90% of patients, classically described as sharp and pleuritic and improved by leaning forward, worsened with laying down. EKG changes are also quite common, seen in up to 60% of cases, and classically described are ST elevations with PR depression. Effusion is seen in about 60% of patients, and rub is actually less common. It's seen in about a third of patients. So broadly, we can think about acute pericarditis into infectious or non-infectious etiologies. And in developed countries, the vast majority of cases are viral or idiopathic. And for the idiopathic cases, we usually presume that those are either viral or post-viral. And we oftentimes don't find a causative etiology. It is important to note that in non-developed countries and areas with high rates of endemic tuberculosis, that is a significant potential cause of pericarditis. And so that has to be considered in those patients, as obviously treatment would be different. There are a number of other causes. This is a really busy chart that you're not intended to read everything. I just wanted to show you there are a ton of things that can cause pericarditis. Less common causes would be systemic disorders like rheumatologic conditions or renal failure, malignancy, bacterial or fungal infections, or Kawasaki disease. We do not always do a full workup for all of these things unless there's something about the clinical history or the patient's presentation that makes us more concerned. So if a patient came in and had a year's worth of vague, non-specific symptoms, then maybe we'd think about a more systemic process. But a lot of times for a patient coming in with new onset pericarditis, we assume it's viral or post-viral. So this is considered testing when thinking about acute pericarditis. I want to reiterate that not all patients will require all of this testing. And so it's possible to see a patient in an outpatient clinic and not do all of these things. But these are things that could be considered, particularly depending on where a patient is being seen. So EKG is pretty much always obtained. Labs are not always required, but if a patient's being seen in an emergency department, it's reasonable to check a troponin to assess for myocardial involvement and to check inflammatory markers, which can be helpful to track disease progression. Chest x-ray can be helpful. If we're seeing a patient in clinic and getting an echo, we won't necessarily get a chest x-ray, but that can give us information about whether or not there's concern for effusion based on the size of the cardiomediastinal silhouette. And then echo. If we're concerned about pericarditis, we will do an echo to assess for effusion and to check the ventricular function. Echo is normal in a good proportion of patients, and chest x-ray is also frequently normal. It takes a fair amount of fluid to develop enlargement of the cardiac silhouette. This is another EKG. I think this one's a little bit more impressive than the one that actually went with my patient, so I put this one in here. But you can see here diffuse ST segment elevation. In terms of treatment for pericarditis, so the first thing that we do is we exercise restrict while a patient is symptomatic. Scheduled NSAIDs are a first-line treatment. You can use ibuprofen or naproxen. Naproxen is really nice as an outpatient because it's twice daily dosing, so it helps with compliance. Colchicine is recommended in the adult guidelines to improve response to medical therapy and to prevent recurrence. I would say its use is less consistent across pediatrics. My practice is a bit biased because the vast majority of patients I've seen have been in the inpatient setting, which means that they are, by definition, tend to be a little bit sicker. So I have typically started my patients on colchicine. That being said, if a patient was seen in an outpatient clinic, had no effusion, was doing well, it would not be unreasonable to just start with scheduled NSAIDs. That being said, there is a much higher risk of recurrence in patients who are not treated with colchicine, and colchicine has been shown in studies to have the recurrence rate of pericarditis. When you start colchicine, you usually do that in conjunction with scheduled NSAIDs, so you'd be on dual therapy. Steroids are third line, and we try to avoid them. They can be used in patients in whom there's a contraindication to NSAIDs or in a patient who has incomplete resolution of symptoms with the typical therapy. So patients on scheduled NSAIDs and colchicine with ongoing symptoms or worsening of effusion. The trouble with steroids is that they tend to result in very prompt normalization of the symptoms, but they greatly increase your risk of recurrence of pericarditis. And so in patients who require steroids, they typically need extremely long tapers to prevent recurrence as the steroids are taken off. Rarely we have to use immunosuppressive or immune modulating drugs like IVIG or anakinra. I personally have not had to use any of these in my practice, although we did have a patient recently who was started on them. If we're getting into this realm of treatment, I think we need to start thinking about whether something more systemic is going on, like a rheumatologic condition. And usually if we're starting those medications, we'd be getting rheumatology involved. In terms of activity restrictions, so activity restrictions for pericarditis are a bit more variable. And I think if you ask 10 people in our practice, you may get 10 slightly different answers. And it depends a little bit on what guidelines you look at. Certainly, while patients are having symptoms, we would typically recommend exercise restriction from strenuous activity. The European guidelines actually recommend restriction beyond sedentary life until the EKG symptoms have resolved, EKG is normalized, and labs have normalized as well. And then some people arbitrarily state 3 months of restrictions, probably basing that a little bit off the myocarditis guidelines, which we're going to talk about in a little bit. So the patient that I started with, he was admitted, as I mentioned, from clinic. He was started on colchicine and was actually transitioned to Toradol to see if that would help with symptom control. Unfortunately, he had climbing inflammatory markers and ongoing symptoms and was having pretty high fevers. We did actually end up tapping his effusion because of the fever and the elevation of his CRP, which was reassuring against a bacterial etiology, and he was started on steroids. His symptoms improved almost immediately, but he is now requiring an extremely slow wean of steroids as an outpatient. All right, so let's move on to our second case. So this is a 17-year-old previously healthy male. He had a febrile illness with negative viral testing from which he recovered. And 5 days later, he developed the acute onset of severe and crushing chest pain for which he presented to an outside hospital. At the outside hospital, an EKG was obtained, which showed nonspecific STT wave changes. And this is his EKG. You'll notice it's not terribly dissimilar from the prior patient. He's got diffuse ST elevations in pretty much all of the leads. Labs were checked, were notable for normal electrolytes. The first labs are on the far left of the screen. So you'll notice that his electrolytes were normal, his BNP was normal, and his troponin was elevated at 17.4. Since this patient was seen, we've actually changed the lab normals at Eggleston, and so we now have a different upper limit of normal, but at the time of these labs, the upper limit of normal for troponin was less than 0.045. So his troponin of 17 was markedly elevated. He also had some mild LFT elevation. Given his lab findings, an echo was obtained, which showed mild to moderately depressed LV function, but no effusion, and he had a cardiac MRI. MRI was notable for normal RV size and function, normal LV size with mildly depressed LV function, and findings indicating edema, hyperemia, and fibrosis. So he met MRI criteria for myocarditis. So I've already given it away, but the diagnosis is myocarditis. So myocarditis is an inflammatory injury of the myocardium, which can also involve the conduction system and the pericardium. And it's fairly rare. It occurs in up to estimated 4 to 15 per 100,000 people per year globally. This is a really nice review article. It's short. It focuses on diagnosis and treatment of myocarditis. And it's a nice read if you want to learn a little bit more afterwards. And the citation's at the end of my talk as well. So myocarditis is an inflammatory condition with injury of the myocardium. It occurs after there is immune-mediated injury, and pericardium can also be involved, as I mentioned, as can the conduction system. It is typically post-infectious or infectious. Up to 80% of patients presenting with myocarditis presented with a prodrome of flu-like illness, respiratory or GI symptoms. Viruses that are commonly implicated are Coxsackie virus, adeno, parvo, CMV, EBV, flu, and COVID. It can also be seen with immune checkpoint inhibitor therapy. That's seen in about 1% of cancer patients being treated with these therapies. As we're all no doubt familiar, we could also see it post-vaccine. This was very well reported after the mRNA COVID vaccines. And then finally, in some patients, there may actually be an underlying genetic abnormality that results in a myocarditis-like presentation. So we have had a few patients that I can remember over the past several years who have come in with what appears to be an episode of recurrent myocarditis, so a second or third episode of myocarditis. And in those situations, genetic testing is often undertaken, and those patients may actually have a genetic abnormality that is presenting like myocarditis. Typically, myocarditis presents with chest pain, can also present with arrhythmia, syncope, or dyspnea. And in the case of fulminant myocarditis, patients can present quite sick and in shock. For testing, we usually do the gamut. EKG, the vast majority of patients, up to 90% of them, will have EKG abnormalities. That could be anything from sinus tach to tachyarrhythmias, ST segment changes, heart block, or ventricular arrhythmias in the patients that are very ill. Chest x-ray is usually obtained. That could be normal or could show cardiomegaly or edema if there's cardiac dysfunction or if there's effusion. Labs, elevated troponin. So by definition, if you have myocardial involvement, you need to have evidence of that by lab. So your troponin should be elevated. And then inflammatory markers tend to be elevated as well. Echo can be normal, or you can see dysfunction, effusion, regional wall motion abnormalities. Definitive diagnosis can be obtained by MRI or biopsy. Biopsy was used more historically. It is very rarely done now for two reasons. One, MRI is available and is a very good test and is very low risk. Biopsy probably doesn't take much imagination to think about the fact that biopsying an inflamed myocardium is probably not the least risky thing you can do. So we almost never do biopsy anymore for definitive diagnosis. This is a different patient than the patient I was talking about. This is a much younger patient who came in quite sick with fulminant myocarditis. And you can see on x-ray they had a markedly enlarged cardiac silhouette and then pulmonary edema. And then these are two very concerning EKGs for patients who came in with myocarditis. The top shows heart block and the bottom shows a pretty ugly ventricular arrhythmia. I'm obviously not Dr. Wilson. I am not a 3D imaging doctor, so I'll just put this one picture up there. Cardiac MRI is now one of our mainstays in diagnosing myocarditis. It allows for assessment of function, chamber size, and for the presence of effusion, inflammation, edema, and fibrosis. And there are cardiac MRI diagnostic criteria that you must meet to be diagnosed with myocarditis. So we routinely do these on our patients if we are considering the diagnosis. There is a wide range of presentations of myocarditis, from uncomplicated, in whom patients may present with isolated chest pain, but with preserved function on echo and no arrhythmias. In those patients, vital signs will be stable to perhaps mild tachycardia. On the other end of the spectrum, you can have complicated myocarditis coming in with ventricular dysfunction, arrhythmias, and then fulminant myocarditis, in which patients present with shock requiring inotropic or circulatory support. Myocarditis can result in sudden death, but the overall mortality from myocarditis is quite low, 1 to 7% in all comers. That being said, fulminant myocarditis has pretty bad outcomes. There's a 48% estimated mortality or need for heart transplant at 7 years in adult studies. So patients with uncomplicated myocarditis tend to do quite well. Those with complicated myocarditis, particularly fulminant myocarditis, may have more long-term sequelae. Oftentimes, no treatment is needed for patients with uncomplicated myocarditis. We do sometimes use NSAIDs for pain control, but oftentimes those can be stopped once pain is gone. For patients who come in with more severe cases with evidence of arrhythmia or dysfunction, we do sometimes use IVIG or steroids. Especially patients who are in the ICU, we sometimes go with the kitchen sink mentality and kind of give everything. But the data on IVIG and steroids is not great. So we do sometimes use it, but it's typically reserved for those patients who are more ill. If patients are having arrhythmias, they will be in the ICU, and we will treat arrhythmias as needed. And then if patients have persistence of heart failure symptoms or findings, they could be started on oral heart failure regimen. And for patients who come in with fulminant myocarditis, they again are in the ICU and could require inotropic or circulatory support like ECMO. We do typically admit patients with myocarditis. Myocarditis is associated with potential for arrhythmias, and so patients are typically admitted and placed on telemetry at the time of diagnosis. We do usually obtain a baseline echo and then get an MRI to confirm the diagnosis and to obtain a baseline study. Most people trend the troponin until it's downtrending, the thought being that you should remain inpatient and in a monitored setting while you have evidence of worsening myocardial involvement to make sure that no arrhythmias develop. Once your troponin is moving in the right direction, we'll oftentimes discharge. Echo is repeated if there's any significant clinical change or if the patient is not progressing as we would expect them to, just to see if there's been any change in function or development of effusion. The activity restrictions for myocarditis are actually very well laid out. And I think these are probably fairly consistent across providers in our practice and across the country. Patients are exercise restricted. We know that myocarditis can result in arrhythmias, which can be precipitated by exercise. So patients are restricted from strenuous activity for a minimum of 3 months. The guidelines actually say 3 to 6 months. Return to sports typically entails documentation of normal rhythm monitoring, meaning that we have patients wear a patch monitor, an exercise test, which shows no evidence of exercise-induced arrhythmias, normalization of their MRI findings, and normalization of lab markers. So we really should be showing normalization of the MRI and normalization of the troponin prior to clearing to return to sports. This is those recommendations essentially summarized. This is from the AHA and ACC eligibility documents that sort of lays out restrictions. So again, I think within our practice, most people follow these. Typically, what we will do is obtain all of that repeat testing at 3 months in hopes of keeping the period of restriction to as short as possible. So that patient, I followed him in clinic since 2020. His troponin downtrended and he had no arrhythmias noted on telemetry. When he was discharged, his LV function had improved, although it was not quite normal. I got a repeat MRI 3 months after presentation, which showed that his LV function was now low normal, but all of the other MRI findings had resolved. He had an exercise test that was normal, a patch monitor that was normal, and a troponin that had normalized. So I followed him closely, and I actually saw him earlier this summer. His echo had looked better, and so I repeated an MRI, and his LV function has now normalized, and he has no sequelae of his prior myocarditis, so he is doing great. So in conclusion, things that should raise consideration of further testing or workup for patients with chest pain, I would say if there's concerning physical exam findings, so patients who have a rub, a new gallop, a new murmur, or impressive vital sign changes, so marked tachycardia, symptoms that are worse when supine or improved with leaning forward, sudden onset of severe chest pain that's been associated with recent illness, fever, or other systemic condition, or symptoms associated with palpitations or syncope. I do think it's worth noting that patients often self-select and present to the emergency department. So both of these patients looked sick and both of them went to the ER because their chest pain was that severe. So that does sort of make me feel a little bit better when I'm seeing some of these patients in my outpatient clinic who've been having pain for months. And then lastly, I want to reiterate what Dr. Wilson said, which is that we are always available. We're happy to chat and see if we think further testing would be helpful or if it's needed or further workup is needed. So if you ever have a question, we're happy to help weigh in. And usually I would say if you're worried, we're always happy to see patients in clinic. And these are the references that I mentioned of the 3 articles that I put up.
Thank you so much, Dr. Jones. There were a few questions that came through. So before I go to my summary, I was just gonna pop back up and make sure we don't miss anyone's questions. Dr. Tenenbaum said, in a 12-year-old female, otherwise good health, how would you proceed when she complains of feeling dizzy at rest, but no problem with activity? And Dr. Wilson actually answered this, but I want to make sure everyone in the group could see it. Dr. Wilson, do you mind just kind of going over your answer?
Oh yes, apologies. I jumped the gun a little bit in the
No, that's
the text
okay.
response. I'd say you know, I'd approach it like I'd say to the family that it's actually reassuring that your daughter's not having exertional symptoms. That's actually, I think, reassuring against an underlying cardiac cause. Depending on how significant the symptoms are, the symptoms that fall in the vasovagal or orthostatic category will often, emphasize the conservative measures which can mitigate recurrence. So emphasizing good hydration, good sleep, breakfast in the morning, not texting friends late at night and sleeping for 6 hours, things like that. For patients with really debilitating symptoms, we'll sometimes consider medications, so fludrocortisone or midodrine. And then for patients with kind of refractory to those measures, I found some guidelines helpful that suggest like an exercise regimen and a way to kind of rehabilitate. So that's probably getting a little bit on the farther end of the spectrum, but long answer to a short question.
There was another question, I think probably more directed towards your talk, Dr. Jones. In the COVID-19 era, would you include testing for recent COVID? I'm assuming with the pericarditis and myocarditis, so I'll tell you from my experience consulting in the ED, certainly like when COVID-19 was first kind of hitting, we were seeing myocarditis, but it was particularly with MISC and I didn't see as much with COVID-19. So if it was 4 to 6 weeks after something that seemed like a COVID infection, then they were doing like COVID IgG testing as well as the workup for myocarditis. Dr. Wilson, I think you said something similar. We have not seen nearly as much of MISC lately.
Yeah, and I would say honestly, myocarditis can present really after any viral infection. So I don't have strong feelings one way or the other. I think we do not infrequently do a viral swab in patients, especially if they have any viral symptoms. But that looks, our new swab has everything on it. So.
Mark asked, how long must a patient be in MRI to obtain the study? Is it only minutes or longer? And Dr. Wilson, the expert on this, answered it's 45 minutes. It's usually done without sedation if the patient is older than 9. We also usually give contrast unless there's a contraindication. And patients can choose their own video. Per Dr. Wilson, Ironman is very popular.
It's like
and
Ironman.
then cardiac CT is shorter. It only takes a few minutes, but doesn't provide as much tissue characterization compared to MRI. Okay.
Hey, just want to make sure everybody knows that we have an evaluation form that must be completed to receive your continuing medical education credits. I
Yeah.
dropped a link in the chat box, but I think Dr. McKay may also have a QR code that she can put up on the screen.
Yes, and I am going to reshare my screen. I have just a couple more slides for you and that QR code, and then we can kind of see if there's any questions at the very end. Let me get to that slide. Can you guys see my slides again?
Yep.
Okay, great. So this is just kind of the summary of the chest pain algorithm from CHOA Cardiology. So it's really looking at when you should obtain a further cardiovascular evaluation. So the pain features, we've covered a lot of this. Is it acute onset? Is it positional? Is it with exertion? Are there associated symptoms like syncope, palpitation, shortness of breath? Are there any other symptoms that worry you, like syncope, extreme fatigue, like not being able to complete your normal physical activities? Are there other components of the medical history, like Dr. Wilson mentioned Kawasaki? Also, if you have Marfan syndrome, Turner syndrome, things that we know increase the risk of aortic dissection and aortic disease. Do you have congenital heart disease? Those are all reasons we don't blow off chest pain and we would do a further evaluation. Also, family history, like any sort of cardiomyopathy, connective tissue disorder, aortic disease, physical exam features. Dr. Jones touched on a lot of these, but fever, things like a rub, a pathologic murmur, a click, any signs or symptoms of connective tissue disease like Marfan syndrome, Kawasaki disease, signs of heart failure like we talked about, xanthomas like Dr. Wilson talked about. Those would all be reasons to proceed with a cardiac evaluation. If none of those things are true, and like I mentioned, if it's long-standing, it's chronic, it's fleeting, it's not really limiting the patient, then in all likelihood, it's probably benign non-cardiac chest pain, and we wouldn't do an extensive evaluation for it. All right, and I think that closes it out. We have a couple more minutes for questions, but I just want to give you both Dr. Wilson and Dr. Jones a huge thank you. I also want to thank our marketing team. Jack and Katina have been incredibly helpful. I want to thank all of you guys for attending and spending your evening with us here learning. We appreciate all of you guys do. And just like Dr. Jones and Wilson said, while the goal of this talk was to give you empower you, to give you the knowledge and comfort with dealing with chest pain, we are always here. We're always happy to take referrals. So while we really drilled that most chest pain is benign, we're always happy to help tease it out if you have any questions or concerns and see those patients in clinic. And then as Jack mentioned, here is the QR code. This is what you're going to scan to complete the evaluation. There is in the comment section where you can break down feedback for each speaker. We would love to hear not only what you thought of the webinar as a whole, but also each speaker. So please complete that, and that's the way you'll get your CME credit. And like I said, we have a few more minutes for questions. If any people have, I think, let me scroll up in the chat. With a family history of cardiomyopathy, is a genetic evaluation of an adolescent be predictive of the condition, or does one wait for symptomatology? So we don't necessarily wait for symptomatology. So especially if it's a first degree relative or it's multiple generations in a family of known cardiomyopathy or just like really young disease, that's always a good patient to send us. We have wonderful genetic counselors who can help us obtain the parents' records if it's the parent. We can even, in some cases, I've been able to do post-mortem genetic testing on a first-degree relative. So we definitely don't just wait for symptomatology. We screen those kids, especially if it's a first-degree relative. We do an echo EKG, and we see them back every couple of years if it's a confirmed cardiomyopathy. And we really try to get genetics done to see if they've inherited the pathologic mutation. Any other questions? Could it possibly be that we will finish promptly at 7 p.m.?
Mm-hmm. Mm.
All right. Oh, contact info for our clinics. I will put our number in the chat box. That is the mainline number to schedule for parents to call, or if they are one of our patients already, we have a nurse advice line where a nurse or a cardiology fellow or a cardiology attending is covering for our parents who have any questions. All right. Don't forget, if you have any like recommendations on future webinars you'd like to hear, put it in the chat box. All right. Thank you all so much for your time.
Thank you.